Everybody makes mistakes, even doctors.
You forgot to say...
I forgot to say clear.
All right, so welcome to the overview on EKG interpretation. So this is a basic lecture on an approach to interpretation. So the objectives of today's talk will be building an approach to reading an ECG, identifying myocardial ischemia, identifying blocks, identifying tachyarrhythmias and bradyarrhythmias, as well as some other miscellaneous ECGs that I think are important to know. So before you interpret an EKG, one of the most important parts of EKG or ECG interpretation is being able to compare your current ECG that's sitting in front of you with any previous EKG that is available. And a lot of times, when somebody will hand you an EKG, usually they'll have printed off previous ECGs available. But if that's not the case in your shop, then I would advise you to at least go back into the chart and pull up and print off at least 2 previous ECGs for your comparison. It's important because, in previewing a previous, any, subtle changes or even minor changes between EKGs can have pretty significant implications in the right clinical context. So reading an EKG can be intimidating at first, but the key is to really form an approach, a systematic approach that works best for you. And a lot of people teach different ways of approaching this, and hopefully with our approach here, you'll build off of that, and hopefully it works for you as a basic approach. So this is going to be an approximately 8-step process to reading an EKG. So I'll run through the steps really quick and then we'll go into more detail. But step 1 is reading the rate. Step 2, identifying the rhythm. Step 3, identifying the axis. Step 4, evaluating the intervals. Step 5, evaluate the P wave. Step 6, reading the QRS complex. Step 7, evaluating the ST segment and T wave. And then step 8 is putting it all together with an overall interpretation. So you may have learned in school a quick estimate of identifying rate is to pick out an R wave and count consecutive boxes until the next R wave. So the quick estimate is 300, 150, 100, 75, 60, and 50. Alternative methods, you can count the 6-second strip and multiply by 10. You can also count the number of beats on the EKG and multiply by 6. And by beats, I mean count the R wave progression. So next is to determine, is this sinus rhythm? And we're looking at the rhythm here. So in quickly evaluating, is there a P wave before every QRS? Is every P wave followed by a QRS? And is this regular or irregular? So then next we'll look at the axis. Now there are multiple ways of evaluating the axis, but I think most importantly is a quick determination. And so for this we look at leads 1 and leads AVF. And so here we're looking at the QRS deflection from the isometric line. So for example, lead 1, if it's a positive deflection or the QRS is going up from the isometric line, and there's a positive deflection in the lead AVF, this would be a normal axis. Likewise, if lead 1 was positive and AVF is negative, we would say that this is left axis deviation. Now, if lead 1 is negative in its deflection and AVF is positive in its deflection, then we would say this is right axis deviation. And lastly, if lead 1 and AVF are both negative deflection, then we would say this is extreme right axis deviation or extreme left axis deviation. One quick pointer here, or a quick tip that I learned, is that if you take both leads and if they're pointing at each other, for example, if lead 1 is negative pointing down and AVF is positive pointing up, so they're pointing at each other, then they are, quote, right for each other, which would indicate right axis deviation. Similarly, if they're pointing away from each other, for example, lead 1 pointing positive and AVF negative, then they have left each other, and that's left axis deviation. Next is important for evaluating blocks, specifically atrioventricular blocks. So for example, first degree block, the PR interval is fixed and greater than 0.2 seconds. Second degree block, or a Mobitz type 1, the PR gradually lengthens and then drops QRS after that. Second degree block, Mobitz type 2, the PR interval is fixed but dropped QRS complexes at random. And a type 3 block, the PR and QRS are completely dissociated. Next, we'll evaluate the intervals. The PR interval, so the normal PR interval is 0.2 seconds. That is approximately less than one large box. The QRS, normal QRS, is less than 0.12 seconds. That's roughly less than 3 small boxes. The QT interval. Now this has been varied somewhat, but in general we say 450 milliseconds in men and 460 milliseconds in women. This is obviously based on gender, and the heart rate also impacts the QT interval as well. With a normal heart rate, it's usually less than half of the R to R interval. The QTC, or the corrected QT, is pretty reliable based on the EKG calculation. So you can generally rely on the reported EKG calculation for QTC, but this corrects for the heart rate, and it is also accompanied by a complex mathematical equation. Normally, I would advise not looking at the interpretation of the ECG, but it is okay and reliable to look at the actual measured intervals on the ECG itself. So let's look at a little case here. So this is a 17-year-old female found by her roommate while at college, found to be unconscious. Just kind of quickly look and form your general interpretation of this ECG. So what you'll notice is that the QT appears prolonged in this ECG. So some things that you need to be thinking of in the unconscious patient who you've just obtained an ECG from looks tachyarrhythmic with prolonged QT. So some of those things that can help us hone in on and build our differential are, what are the causes of QT prolongation? So these could be drugs, sodium channel blockers, for example, antipsychotics. This could also be hypocalcemia, hypomagnesemia, hypokalemia, could also be hypothermia. She could also be experiencing an acute MI. This very well could be congenital. Alternatively, you have an unconscious patient. This could also be accompanied by an increased intracranial pressure. So that's a quick way to evaluate some of the causes for a prolonged QT. Let's look at the P wave in this example here. So it appears upright in lead 2, which is good. That's going to help us identify sinus rhythm. There's a P before every QRS and after every QRS. We can also evaluate the P wave to help us describe any sort of atrial enlargement. For example, left atrial enlargement in lead 2, you can see a bifid P wave with the total P wave duration of usually greater than 110 milliseconds. Again, that's lead 2. Lead V1, we can also see with left atrial enlargement a biphasic P wave with terminal negative portion usually greater than a millimeter deep. And again, that's in lead V1, which you can see here. And biphasic meaning there's an upward and downward, or positive and negative deflection of that P wave. Evaluating right atrial enlargement, lead 2, you can see demonstrated peaked P waves, usually greater than 2.5 millimeters. Also lead 1, you have a peaked P wave in lead 1, usually greater than 1.5 millimeters. So that's a good example of an EKG demonstrating atrial enlargement there. Now moving on to the QRS complex. Some of the things that we want to evaluate here in the QRS are amplitude, and this can help us identify left ventricular hypertrophy, or LVH. We can evaluate the duration, which will help us with bundle branch blocks. We can look at the Q waves and help us identify any old MIs, which is a good reason for evaluating previous EKGs when comparing to your EKG that's sitting in front of you. And we can evaluate the R wave progression. So generally with amplitude, there are several approaches in this, but generally we say you add the larger S wave of V1 or V2 in millimeters to the larger R wave of V5 or V6. And that helps you determine a normal amplitude. Duration, normal duration of the QRS is generally less than 0.12 seconds. If it's prolonged, which again you can rely on the calculated measurement of the EKG itself. Just remember, interpret your own EKGs, don't read the interpretation, but it's okay to look at the measured values of each interval. So if we have a longer duration, greater than 0.12 seconds, then we have to think this is prolonged. We have to consider a right bundle branch block or a left bundle branch block. For left bundle branch blocks, there's generally a dominant S wave in V1 and a broad monophasic R wave in the lateral leads, 1, AVL, V5, V6. So generally, V1, you'll see a W formation, and V6 an M formation, as you can see here.